Thank you all for joining us here in the machine learning and science session of MLconf. Today, I'm pleased to welcome Yin Aphinyanaphongs, Director of Clinical Predictive Analytics at NYU Langone. Today, Yin will present the talk, Development, Integration, Deployment, and Use of a Validated Real-Time Prediction Model for Favorable Outcomes in Hospitalized COVID-19 Patients.
All right, thanks for that introduction. So let me just jump right in. Clearly, COVID's going on. I did not I decided not to show an image of that, but just to let you know, right, New York was one of the first places, right, to really see these spikes. And in mid-March and April, our facilities were being overrun, and we were getting nearly, I think, 1,000 admits a day. At some point, it was like 1,000 admits a day or something. It was absolutely crazy. But just to give you a sense of our footprint, right, we have 3 main hospitals by the stars. We have a lot of visits, typical academic institution. A lot of physicians also have a research arm as well. And we're very, very IT focused. So a lot of the success of getting this model out into clinical practice has to do with the fact that, we are IT focused, and a lot of the connection between IT and hospital leadership is one and the same. So that makes it possible to deploy some of these things. I run a predictive analytics unit, so I am let's see. Oh, there it goes. I'm a physician scientist trained in medical informatics at Vanderbilt, focused on machine learning and text classification. Academically, I'm an assistant professor, teach a bunch of courses. And then also on the operations side, I am director of clinical translational data science and clinical predictive analytics. I run a team of data scientists and engineers. Our job is to provide a capacity for predictive modeling to increase operational efficiencies, drive value, translate AI-based models to point of care, lead specific projects from inception to evaluation. We have a master's, a PhD program, a clinical fellowship, and soon we'll have a certificate program. So we're trying to create an organization that's used to thinking about data and making decisions based on data. And then we're a central umbrella organization for clinical data science. We have collaborations with Microsoft, Facebook, and all the head guys in terms of with their research arms doing innovative research in healthcare. So why am I here? I'm here really because of a broad frustration. So Eric Topol published this about 6 months ago. In that bottom right-hand corner, you can see that there's just so much work done on AI medicine research. And there's a lot, there's literally, just tons of papers. And early in my career, I was one of those guys that was writing all these papers. And I sort of said, this is super frustrating because, we're doing this really awesome stuff, but nothing's making it into clinical practice. And that was super frustrating. And so about 5 or 6 years ago, we brought together, I made a pitch to my leadership and said, hey, look, we need some sort of translational group that's sole job is to think about how to translate these AI models to the point of care. And they're scoring systems especially are not novel or new in medicine. If anything, they're probably the very first application of sort of predictive modeling. So things like PORT, CHADS2, Charleston comorbidity, Apache 2, you may have heard of some of these, or you may not. But they're quite ubiquitous. And some of these are used, but they're not used as much as you'd think. And so our challenge is to try to figure out what those problems are and why. There are some translational barriers. One, there's some technical challenges. So, we really have poor coupling of model predictions and interventions. So, I have a model that might predict readmission, right? So readmission is, you get discharged. If you come back within 30 days, there's a penalty that's applied to that readmission, and it's considered to be the hospital's fault. And so let's say I predict readmission, right? Well, what am I supposed to do for that patient? And how do I actually prevent their readmissions? And sometimes there's a really poor coupling between why a person may come back and what are the interventions that are possible to prevent that person from coming back. Some hospitals have difficulty compiling their data. A lot of hospitals are conglomerations of many different hospitals that might be running all kinds of different electronic health record systems. And bringing that all together under one roof can be very difficult. We don't have that problem at NYU because we're all one system, both in the outpatient and inpatient world. Limited evidence of efficacy. So once you apply that intervention, does it actually have an effect on your outcome? And typically you would do this in a randomized control trial, right? So you'd have a drug trial that would show that a drug was efficacious, and we just don't have a lot of that kind of data in the AI healthcare space. It's difficult to apply models at the point of care. So, we have Port, CHADS, Apache, the ones I saw before, and, they do exist. And sometimes physicians will pull out their calculator, right, or their iPhone and type in the values, right, to get a classification. But that makes it a little bit, it's even more friction, right, to apply these. And how can we do this in an automated way? And then poor precision and recall. So there are models that work well, right? We'd say in like the 0.85s, the 0.9s, AUCs, but ultimately, right, the predictive values are too poor to actually drive an intervention, right? And so this is constantly on our mind whenever, I present our models to leadership or otherwise. The question is always, well, how many, if say I do that intervention, right, how many false positives are we going to identify? And is that intervention actually detrimental to the patient? And then some social barriers. There's variable health professional training on how to use technology and what it does, limited training at the leadership level to understand model value, workflow integration, and change management. So there's one big picture of clinical predictive models that I do want to communicate to you. One is, at the end of the day, we're trying to affect some outcome, right? And the model itself is just one component of this. Other things we have to worry about are things like notification efficacy. So, now that the model is produces a classification, how do I get that out to the clinicians or the providers or someone who cares, right? And how effective is that communication channel? One is, how can I drive that person to take action? And this is where I'll talk a little bit more about our COVID-19 model and how we try and what physicians and providers' reactions have been to the model and how we actually can drive an action. And finally, what's the intervention? So, I might have a readmission model, right? And I can tell someone that this patient will be readmitted. They can take some action, but that action, may not work. So examples like congestive heart failure. So patients get readmitted for congestive heart failure. You put them on Lasix or a diuretic, right, to try to get rid of some of the fluid, but they're not adherent. So then they end up back in the hospital, right? And so even though you have an intervention, right, and you take an action, doesn't mean it's efficacious. And so by the time you finish, you have an outcome that, is that you have almost no signal because you have an amazing model, but you kept on losing signal along the way. So you actually try to measure your outcome of readmissions. So today I'm going to talk about this paper that we wrote, Validated Real-Time Prediction Model, Favorite Outcomes in Hospitalized COVID-19 Patients, published in MPJ Digital Medicine. So if you can find it if you want to look for it pretty quickly, but it's a brief overview of it. So at the end of the day, right, a question is, well, what's useful to predict? And we were asking this very early on. So my team was involved with a lot of the operational applications of trying to help our providers in our hospital make decisions about what to do. So we had models like, who's likely to have a positive test, right? So this was relevant when we didn't have a lot of tests available. Who should be admitted from the ED? Who's likely to deteriorate on the floors, and who is likely to be safe to discharge from the hospital? And so the first three, you might say, oh, those sound like amazing applications and super useful. But it turns out, they're actually not as useful as you think. And, especially the deterioration one, for example, yeah, okay, great. I know I can predict that someone will deteriorate in the next 12 hours. The problem at the time was that there was nothing we could do for them, right? We didn't have any interventions that were possible. So leadership was like, well, that sounds great, but it's not really that useful. However, one area that we did found useful was this idea of who's safe to discharge, who's safe to send to a lower level of care. And the reason is that, we have a lot of traditional measures of who is safe to discharge. And what we found was that with some of these patients, some of the COVID-19 patients, right, we didn't have to be as stringent as we would be with other conditions that people might have, and we might be able to send them home earlier. So what does it mean for safe to discharge? Well, it means a couple of things. One is you don't get transferred to the ICU, right? That's clearly bad. You don't get intubated, which is bad. You don't come back to the ED. So if I send you home, you don't come back to the ED. Also, you're not sent to hospice because that means, you're really sick. You don't die, and you don't have oxygen support in excess of nasal cannula at 6 liters. And so that last one is special because pre-COVID, home health services would not send people home on oxygen. And through this process and, through our trying to manage our bed flow, right, we've sort of, they agreed to send patients home on more oxygen than they're used to. And so that's why, we have this 6 liters per minute. And the idea is, by creating a model to essentially not predict these, right, or find a cohort who won't have these, can I augment a clinician's decision in trying to send a patient home and do it earlier? So a couple different use cases. As a provider, I want to know which of my patients are at risk of adverse events, so I can have charges, so I can discharge the patients. As a dyad leader, I want to quickly know which patients are at low risk of adverse events, so I can follow up with the teams. As a care coordinator, I can quickly prioritize which patients are at low risk of adverse events, so I can prioritize for discharge. How do we develop our model? So, we built a model on all available inputs, and then we did some feature selection to make it parsimonious, and we built that parsimonious model within our electronic health record. Pretty simple. We take a prediction time, and then we try to see whether something happened in the next 96 hours. Our data was about 2 months worth of data, about 3,000 patients. Each prediction was a patient day, so there were 35,621 days, patient days, of which a certain number were positive and the other sets were negative. And then we built a model to try to predict whether that patient would not have an adverse event in the next 96 hours, only on adult patients who are over 18, COVID positive patients over 18. Same definition as I said before. We took most recent lab values, min and max vitals, oxygen rate, oxygen devices, days since admission, and demographics, and we traditionally broke it up in a 60-20-20 split. We eventually built an ensemble model and built one very good model, and then we applied some novel feature selection algorithms using conditional randomization tests to basically create a simplified version of the full model that utilizes only 13 features. You can see here the brown is the black box full model ensemble performance, and the parsimonious model is the one that you see here in blue. These are the features that are the model coefficients for the features. So after we get these simple features, we apply a standard logistic regression to turn these into sort of explainable and just look at the betas and coefficients. You can see what the things that are contributing to the classification are. We break it down into red, green, and blue. And so this was identified by our leadership, also based on our prior readmission numbers about how many people we do readmit. And so this helps to drive the colors that we show the providers when they see this interface. Clinical workflow integration is vitally important. So you need to tell people how this will look and what kind of data it will show you. And so this is how it eventually runs. So it runs every 30 minutes. And it provides explanation. So here you can see a patient that's at high risk and a patient that's at very low risk. And you can see here this a timeline, right, across what their trajectory has been over time and the factors contributing. And you can see that the largest factor here is that, they've had a very high respiratory rate. They're on an oxygen device right now, and their BUN is 39, and then some sort of minor contributions there. And then here, this patient is low, but you can see there are some factors that are contributing to the classification. But the physician's able to look at these and sort of say, oh yeah, okay, right, and then make a decision about whether these are legitimate concerns or whether they're the patient is safe to go home. We do have some monitoring, so we have at least 2 diagrams here. So this shows how often that display I showed you before is refreshed. And this shows you how often people go to this hover bubble and they hover over it. And so you can sort of see that as time has gone on, we turned this on May 18th, right? Our numbers have gone down as well. So there's just less and less refreshes here. And this shows you that there's a way that you can actually add this as a column in your display, which I'll show in a second. And basically people, once they add it to their column, basically keep it on their column. They haven't removed it. The model does perform well over time. So when we built the model in May, it still actually is performant today. And that's important when we think about issues around model drift. How do we evaluate this model? We basically have a digital randomized control trial. So here you can see that column I was talking about. And basically all we do is we hide 50% of them automatically. So the clinician does not see the score. And so our goal, primary outcome, is to look at time from first low risk prediction to discharge. Our secondary is length of stay, and our secondary after that is readmissions, representation, or representation to the ED within 30 days. So this trial is almost finished. It'll finish in the next 2 or 3 weeks. We've enrolled 1,000 patients, or it's been applied to 1,000 patients. So we'll see, whether this has a real effect on patient length of stay. There are some interesting observations, which I just want to talk about because I think they're relevant across other applications of AI in healthcare and AI in general. And I'd love to get some feedback, if you have some thoughts. One is, is in this specific application, we have shown that it significantly decreases provider uncertainty about patient status and potential disposition. So I have an NSF grant where we're studying sort of AI in the workplace. And we have these surveys have went out. And so we've shown that this does help the physicians and the providers make better decisions or more certain decisions about patient disposition. A second is sort of our adoptions over time. And I think this is a common concern with AI models. So in this case, the adoption was sort of strong at first, but once a provider's mental model is formed, the providers don't really use the tool anymore. And this is a problem, right? Because, our thinking is that there's faultiness, right? No matter what mental model the physician may come up with, it's too complicated of a task, that a computer can do pretty well. And so, we're not quite sure how to deal with this, honestly, because at the end of the day, we're really concerned about making sure that, surprising findings, right? Findings that may be contrary to what the provider is thinking, those are the ones that we want to surface, right? Those are the ones where we want to alert someone that, maybe this, maybe you need to rethink, what are you going to do for this patient? And so that's something that we've noticed is that, people use the tool, right? They figure out a mental model, but once they have that mental model, they just don't really use the tool anymore. And our third observation is non-experts. And we've seen also that non-experts are ones that actually benefit the most from this AI model because they don't really have a mental model around, what does a well patient look like? And so this gives them confidence, right, of moving forward. And at the height of our COVID sort of, peak, we were enlisting people that were not hospitalists, in their day-to-day jobs to help manage the patient influx that we had. So this was certainly quite relevant. Unfortunately, fortunately, our numbers have been low. So everyone that takes care of our COVID patients now are hospitalists. So model sharing, this model is available and easily shareable. We have a partner institution who got this model running in about half a day. And we purposely made it with our vendor so that it is easily shareable. So if you represent an institution and this is of interest to you, please let me know and let's chat. And I'll just take a few seconds to talk about success principles. So one is workflow first. So, we thought about what the problem was first, and then we built the AI model. And usually in healthcare, it never works the other way around, where you have an AI model first, and then you try to integrate it into workflow. We had a good leadership buy-in all the way up to our dean. And this is super important because there's a huge team that has to come together to make this work, and that was only possible with their support. False positives have real costs, right? So like a false positive is sending someone home who shouldn't go home. Like that's a real cost. And so we're always very cognizant of that possibility and trying to mitigate it at all times. We have clear organizational boundaries about who's responsible for what in our organization, both in terms of safety, in terms of EHR integration, in terms of model building, and that helps to really delineate who has responsibility and who's going to do what, and that's really important for our success. And finally, this is about augmenting the humans. It's not about replacing the humans. For us, this is just a data point, right, that I provide to someone to say, hey, here's just another something, right, to either support your decision or not support your decision. You make a decision about how to integrate that into the rest of the clinical plan that's going on. And then finally, communicate the surprise. This is what I talked about earlier. We haven't really come up with good ways of communicating, that a patient who you might want to discharge, right, is actually not doing well, or vice versa. This patient is not doing well, even though you think they're doing okay. And so how do we communicate that surprise, right? So now that people aren't going to the tool anymore to look at it, how can I communicate to them times when their decision-making is incorrect and then they can be brought, the tool can be brought to them to show them, oh, hey, look, here's some information about someone that disagrees with you. And it'd be very similar to, in our hospital teams, right? The attending may say, like, I think this patient is ready for discharge. And the resident or, one of the house staff may say, well, I don't think, we should do that because of X, Y, and Z. But in that interchange, right, the human knows that the clinician is trying to make this decision. So how can I get the computer to know that there's a decision that's impending and that what it's suggesting is contrary to that decision, so that it can be brought to the forefront that says, hey, this system says that they may not be, well to go home yet. And so that's sort of what we're working on, is how to communicate a little bit about surprise. So a huge team here to make this work: physicians, leadership, my data science team. And thank you. I'm happy to talk a little bit after the session if you want. We don't get the benefit of meeting each other after these type of talks anymore, but please jot this number down if you can for the Zoom, and I'll be on for a little bit afterwards if you want to chat specifically. Thank you. Any questions?
Hello. Can everyone hear me?
Yep.
Awesome. We do have some questions from the crowd.
Great.
Carlos Alfonso would like to ask, could you please explain a bit more about how you decided the red, green, and
right. So what we did is we looked at our readmission rates, and that's how we set the green threshold. Because we said, look, whatever we build has to be at least, not worse than our current rates. So we looked at our current rates, and then we asked leadership. We just said, hey, guys, how often, if this model predicts that someone is okay to go home, how often do you want it to be right? They said, based on our rates, we want it to be about, 90, 95%. And so that's how we chose the predictive value. And then the orange and red, we just sort of chose half of it, because at the end of the day, people aren't going home red for sure. And at orange, it's not really that meaningful. Probably we could have just made it two colors, green and red, and just called it a day. But it was really the greens that we were focused on and making sure that that prediction was correct. Next question. Maybe, oh, can you guys hear me? I cannot hear anything anymore.
I was on mute.
Oh,
apologies.
That's okay.
There's a second question. Tony asked, for the digital RCT for evaluating the model, how are you measuring that the provider saw the score? Page opens, views, and then how does this overall trend affect the results of the digital RCT?
Yeah, so, and that's sort of like, one of the huge worries, right, that we have. And if there's a reason why we might have a negative outcome, it might be because of that. So, the tools we have in our EHR for monitoring who will, roll over the hover bubble, for example, right? So who hovers over this thing are actually quite limited. And we can't get an exact, in other words, we don't know, these are summary statistics, right? But we don't actually know what providers actually use the tool and what do not. In future versions, that's a feature that they promised us. So that way, I can say, oh, we educated all the hospitalists, but only 50% of them are adopting it, right? Then we can go out and sort of, get the other 50% to say, hey, you really need to use this tool. And in drug parlance, this is very similar to adherence, right, for drug medication. So you might run an RCT for a drug, and usually they're research assistants, right, whose sole job is to make sure the patients take the drug throughout the entire time that they're on it. So that way you can actually show that the drug is efficacious or not efficacious. And to the extent possible, we try to do that. But, because of the large scale of this, we just didn't have a way to communicate with everyone every day to say, hey, are you using this tool? What are you doing with it? And so all of our analysis is a little bit post facto in terms of, just hoping that people are using it and hoping that people are seeing it. And, we'll see what happens. My inclination is that the RHD is going to be negative, and that we're not going to see that half-day median length of stay decrease that we're hoping for, but not because it wasn't useful, but because people aren't necessarily seeing it, and especially the experts, as I was talking about earlier, that do see, that did see the model early on. Like once their mental model has formed, and once they've corroborated, sort of like, oh yeah, greens are definitely okay, right? They kind of stop using the model because they don't know when to go see it or when they're going to get something different. But we'll see. I mean, it is there on people's dashboards, as I saw in this picture here, right, as that column. So maybe it'll catch their eye, and they're thinking of discharging someone in that's red. Then we'll know that. Then they'll go in and look a little deeper to see whether it's a legitimate concern or not.
Thank you for that answer, and thank you for your wonderful talk.
All right. Thanks, everyone. I'll be jumping over to the Zoom, so if you guys are interested in joining me, I'll just show that up there for 2 more seconds. Please hop over, and I'm glad to talk in more detail about anything you've heard.
Yes, and I think we have to move on to the next speaker, but there were some follow-up questions. So Carlos, I see your question. If you have time, please join that Zoom. Thank you.
Thanks.